Hi, my name is Nick, and I'm pleased to introduce our next speaker, Dr. Richard Kvas. Originally from London, Ontario, Dr. Kvas began his northern journey on a 2-year trial basis and has never looked back. Dr. Kvas graduated from University of Toronto in 1991 and family medicine in 1993. Soon after, he opened his family practice and is still doing a jack of all trades, which include, but are not limited to, office work, emergency, trauma, obstetrics, minor surgery, teaching, and of course, his favorite, stroke. He's an associate professor and a big advocate of NOSM, which is Northern Ontario School of Medicine. Dr. Kvas initiated the stroke team at Timmins District Hospital to provide TPA, EVT, and TIA clinics and inpatient management of stroke patients as well. He's a proud father of 2 kids. He's an avid sports addict, loves to play soccer, which he's getting too old for, hockey, getting old, and tennis, never too old for tennis. And he enjoys water sports, which include wake surfing and wakeboarding. I'll pass it on to Rick now.
Thanks, Nick. And that was a very generous introduction. And I'd like to thank Sue Verrilli for inviting me to talk to you guys today and the whole Neo North Stroke Network. I think this is quite an honor for able to be in the company of people like Dr. Singh and everyone that we can convey and talk something else other than COVID, because these things are not going away. Strokes are still happening, heart attacks are still happening. And I think it's important that we cover some of the other things related to stroke, including the complications of inpatient stroke. So I'm originally from London. I am now residing in Timmins and love it in the north. So hopefully you can hear it and see the slides. But I think one of the biggest things for nurses is the advocacy they provide for their patients. I'm so impressed when the nurses say this, Mr. Smith needs this at rounds. And I think this is where you can be not only champions of the patients, but champions of the stroke care path. And you will see what actually needs to get done. On a lighter note, I would like to start with this video from a show called Getting On, kind of explaining how good nurses can be advocates for their patients. And I think you guys need a good laugh, and give me a thumbs up if you enjoy this video.
Extended care, first floor. Okay, Don?
Yeah?
It's the language line to translate.
Oh, Jesus, thank God. Okay, when can they come down?
Right. Oh. They said they can't send someone until tomorrow.
This cannot wait. We need to take care of this right now. Do not let them off the phone. See if maybe we can just tell them what she's saying, and then they can translate it for us.
We're going to try to tell you what she's saying. Okay.
Mahoba chinyam.
Mahoba chinyam.
Mama hoba chinyam.
Mama hoba chinyam. He says that doesn't mean anything.
Chum chimnakin. Chum chimnakin.
Chum chimnakin.
You gotta go up.
Chum chimnakin. He said that doesn't mean anything either.
Chomachai Tromimban.
Chomichai Kromibai.
Tromapine Chomichan.
Chomuchai.
Tromapine Chomichan.
Rumbum chai Chucky chai.
Tromachan Pomipine.
Pomibine. He says that doesn't mean anything either.
Okay, you know what? Put it on speakerphone. Put it on speakerphone, and then they can hear her directly. I think that's.
One second. How do I do that?
Press hold and then intercom and then line.
Well, hold what then what?
Whatever line. Just
right, but how do I know which line?
Because it's blinking. You'll see it blinking.
What
and
blink?
It's flashing in front of you, Denise. Can you see it flashing?
The whole phone is flashing. I don't know how to work this
just, you know what? Hold
phone.
it up. Hold the phone up. Hold it out as far as you can, and then they'll hear what she's saying. And tell them it's something Chinese. We think it's something Chinesey. That's a good one. That's got to be something.
Did you get that? Good. She says, I can't stand this. I wish I was dead. Please kill me. It's Khmer. She's Cambodian.
Cambodian. I knew it was something like that. Okay, note it in the file, please. Thank you.
Thank you so much. What's your name?
So I hope you enjoyed that. Just shows great advocacy on nursing for their patients. It is quite a funny show. It's about 10 years old now, called Getting On. So my declarations, I have no funding conflicts with this talk. I have not received any funding for over 10 years on anything. So I don't have any financial declarations. So the objectives of today's talk will be understanding the roles RNs can advocate for their stroke patients, but also recognize the big 4 complications of inpatient stroke care. And I'm going to review the 4 big ones that I think are important is hemorrhagic conversion, immobility complications, infections, and nutrition. There's a bunch of other ones as well, but I think these are the big 4. And if we have time at the end, we could talk about some other ones as well. So what is hemorrhagic conversion? Hemorrhagic conversion is when blood extravagates across a blood-brain barrier. Now, sometimes you can see little microhemorrhages on the MRI. You see these reports, you see microhemorrhages, and you start getting worried, is the patient bleeding or not? Sometimes these microhemorrhages we actually don't worry about. We worry more about bigger hemorrhages, like the CT scan showing the white area where there's a lot of edema and can put pressure on the brain. So what is the blood-brain barrier? Basically, it's the vessel lumen where it connects to the brain and the actual neurons. I don't think it's important that you have to know any of these factors that can affect, other than there's 4 main factors that affect blood-brain disruption, and it's diabetes. So if their sugar is higher, we actually quote a higher chance of this happening if you do give TPA. So the spontaneous rate of hemorrhagic transformation, if you do nothing, is 1%. If you give TPA, we quote about 5%. If they're diabetic, we quote a little bit higher, 6-7%, depending on how high the sugars are. The higher the blood pressure, the more likely they're going to bleed. Think of just higher pressures, more leaky blood vessels. If they're older, they had older brains, older blood vessels. If they have other factors in the brain that can lead to leaky blood vessels, plaques, Alzheimer's, lots of atrophy. There's lots of reasons that this could happen on its own, more likely if they're older. And then the stroke severity reperfusion. A larger stroke will have a larger volume of brain that's damaged, and you'll have more blood vessels that are damaged that can leak. And then when they do reperfusion, either with TPA or EBT, you've had some damaged brain, then you flush the system with more blood, and that damaged area of blood vessels can sometimes leak. So these are all things we quote to the patient and to the families, that this is a real risk with TPA and EBT, but the benefits usually outweigh the risks in terms of decreasing stroke severity when we intervene with therapies. So how can you tell as a nurse that something bad is happening? Usually you'll see a GCS change, so a Glasgow Coma Scale. I think on most of the care paths, people are doing NIH scores. So if you see their NIH score increase suddenly, or just a general decrease in the level of consciousness, there are certain telltale signs that you can see if it's really bad hemorrhagic conversion. Usually if these microhemorrhages, you will see nothing. And there are very little clinical significance, the little microhemorrhages. It's important to note them, but what you really worry about is if something bad is happening very quickly. And when you might see it is within the first hour of giving TPA. So if you see what's traditionally called Cushing's triad, which is a set of signs on the patient that you can recognize that you might think, oh, okay, the brain is swelling or bleeding more. There's more pressure on the brain. So an increased systolic pressure and a widened pulse pressure. So you'll see the systolic pressure go up and the diastolic pressure go down. If you see that happening, start thinking about it. What the more common thing, usually they're on telemetry to rule out atrial fibrillation, is you'll see a profound bradycardia. I get very nervous when I see a heart rate from 78 go down to 40 or 38, and they seem to be getting worse. That triggers me to repeat the CAT scan and worry about, did this person just bleed? And then you could see irregular respirations and some chain stroke breathing. And I think this is one of the most important ones to check because a lot of the time they go to the floor or the ICU, and then you have to chart on them when they're sleeping or comfortable. And sometimes you can say sleeping comfortably, but then you're questioning, is this breathing normal, or is this, should I wake them up to reassess them? Or maybe they have sleep apnea. So it's a very specific type of breathing that I'm going to show you a video of. What you'll see is periods of apnea followed by rapid breathing. Deep breathing. They're trying to blow off their CO2 that collects when they're apnea. Now this man's on a breathing machine and being monitored, but if you see this pattern of breathing, I would be very concerned. So if you suspect a hemorrhagic conversion, I would order a repeat CAT scan. And of course, in discussion with the physician on call. So these are the times you do want to call the doctor and maybe do a quick glucose, make sure there's no mimic that they're deteriorating from a low sugar, especially if they're diabetic. Repeat the vitals, O2 sats, get them a good blood pressure, see what's happening. And if they're not on telemetry, they should be, but see if they're starting to go bratty on you. And then what you can do is in discussion, hold or stop the TPA if it's running, and repeat the CAT scan. If the CAT scan confirms a large or moderate sized bleed, you will stop the TPA. If it shows a microhemorrhage, it might be up to the physician to decide if they're going to finish with the TPA or not. That depends a lot on the CAT scan, how much hemorrhage, volumes, if there's swelling. And just note that sometimes large infarcts, if you take out a third of your brain or half your brain with a huge infarct, you can get a lot of swelling on your brain. And it can mimic the signs of hemorrhagic conversion just from swelling on the brain itself from damage. So sometimes you get that repeat CAT scan and you swear, oh, I thought it was hemorrhaging, but it's not, it's just a really bad stroke. And that's why the mortality of stroke is 15%. Sometimes big strokes end up with big problems and you can even die from a stroke. The next big problem I want to talk about is immobility. There's a whole host of problems with immobility. If you can't move, you're going to get into a lot of problems. And this is one of the sort of biggest complications of inpatient stroke care. So the biggest one we want to talk about is DVT prophylaxis. If you're bedridden, if you have a moderate to high NIH score, which means a large disability, patients are going to be lying around for a long time in a bed. The biggest risk is getting the DVT and that DVT dislodging to form a pulmonary embolism. So patients, this is straight from best practice guidelines. Patients at high risk of venous thromboembolism should be started on a thigh-high intrapneumatic pneumatic compression device or pharmacological venous thromboembolism prophylaxis immediately if there's no contraindications. And one of the contraindications is a big intracranial hemorrhage. But this is level evidence A, and there's no evidence to suggest which one is superior. So I know our hospital chooses low molecular weight heparin, and there might be reasons for that: device costs, availability, actually ease of nursing. I think it's a lot easier to give a needle than put these things on, but there is good evidence that they're quite helpful. They're controlled by machine. They inflate the pressure intermittently. They sink, trying to build up the pressure from the veins of the lower calf to the thigh. So they will help prevent DVT, and there's good studies that they're actually very beneficial. A little bit more labor intensive, I think, to apply. If they ever get urine on them, you gotta clean them, a stool. Like, you can kind of see that this is a bit more labor intensive, but the evidence actually suggests it's quite good. If this IPC is selected, it should be applied as soon as possible and within the first 24 hours after admission. It should be discontinued when the patient becomes independently mobile, either at discharge from hospital or if the patient develops any adverse events, ulcers, pressure sores, or by 30 days, or whichever comes first. So if they become mobile in a week, you can take these things off. And even that decision for if you do low molecular weight heparin, if they're starting to get mobile, you have to actually remember, well, maybe we should discontinue this low molecular weight heparin, just because it does increase your bleeding risk by a little bit, whether it's GI bleeding, intracranial, everything. So low molecular weight heparin is what we use. Enoxaparin should be considered for patients with acute ischemic stroke and high risk for venous thromboembolism, or you can use unfractionated heparin with renal failure. And that's a level A evidence, so it means it's strong. They just use different levels of the alphabet when A means the strongest evidence on the studies, B and C as sometimes is specialist opinion. So if your stroke patients are admitted to hospital and remaining immobile for longer than 30 days, the use of ongoing venous thromboembolism prophylaxis with basically low molecular weight heparin is recommended. That level of evidence is C. Again, that's the biggest complication of being bedridden or in a chair, is you just sit all day and you can get a clot in your legs. And if that clot dislodges to your lungs, big bad outcomes can happen. Now, this is what I think is interesting, because this is what we used to do a lot. The use of anti-embolism stockings alone for post-stroke venous thromboembolism prophylaxis is not recommended. So those tight stockings that go up to your tibia and shin that all my patients in the office hate because they cut into their skin. It takes them half an hour to take them on and off. They need stretching devices. This is what we used to do a lot of. And I think it still happens, honestly. Are not really recommended, and that's level A evidence. So they take a long time to put on and off. They really don't show any evidence to prevent DVTs. So if you're going to choose the fancy pneumatic devices, and if you have them, great. If you only have one or two for your hospital and they're already being used, make sure they're on something. So I would probably choose low molecular weight heparin. And if you don't have those machines, don't just rely on the old stockings that no one really likes and they don't actually do anything. So another thing you should be assessing, getting away from the DVT risk, are temperatures, because temperatures lead to other problems. So it's part of our care pass, ideally every 4 hours for the first 48 hours, and then some routine vitals. But if you start to see a temperature, not a 37.5 temperature, but a 38.5, 39, this should trigger some thoughts. Okay, what's happening with this patient and what is triggering this temperature? I like to see 2 temperatures in a row, 4 hours apart, to see before you get a trend. Unless you get a single temperature at 39.40, I think that warrants a call to the physician to start the process of investigating that. And usually an infection leads with a temperature with a fever, and they start getting sweats, chills, they feel cold. And this is part of your routine monitoring. The first question I had to mention in some talk here is it COVID? Everyone's worried about COVID. It is the most prevalent thing we're talking about right now. So if you develop a fever, if someone has a cough, maybe they have COVID. To be honest, they're probably going to be swabbed when they're admitted. So hopefully you'll have a rapid or PCR test to check if it's COVID. And this, I promise, is the last time I'm going to mention COVID in this talk, because there's enough talk about it. But think about it. The more common thing for strokes are aspiration pneumonias. So you can see this chest x-ray, lots of white fluffiness everywhere, infiltrate, right, usually goes down the right main stem bronchus, because the angle of the right main bronchus is more acute, and most things go down there. I think there are ways to prevent this. And the risk for aspiration pneumonia are mostly patients who are dysphagic from the stroke. And maybe an adequate screening tool wasn't done initially, because they were admitted on a Friday night. There's no speech pathologist. There's no one in the emerge, or no one to do a screening tool. We use the TOR-BEST screening tool, which is the Toronto Best Swallowing Screening Tool. And it's basically feeding some water to the patient, see if they cough, sticking their tongue out, see if they can say, oh, and see if they choke on the water. If they fail that screening tool, you should not be feeding this patient. NG tubes are a big decision we have to make. And do they get dislodged? For sure, are they a cause of aspiration pneumonia? Sometimes you will see some liquid coming up if you lay them flat and you're running your NG tube. So you have to be very careful with NG tubes as well. Make sure they're in the right spot. When you change NG tubes, always order an X-ray to make sure it's in the right spot. Sometimes stroke patients don't have a great gag reflex, or they can't really tell you that their NG tube is in their lungs if they're not coughing. And then my favorite, and I'm sure everyone has seen this, is the family comes in, says, oh, poor Johnny, and feeds them their favorite banana muffin. And you see it all over their shirt here, because obviously they can't swallow it. And then it ends up in the right mainstem bronchus. It's very important when you have that whiteboard in front of the patient to say thickened fluids, what they're allowed. And when you see family coming in, say, please run by anything through us if you're going to feed them. So another common source for temperatures and fevers are UTIs. And here's an obvious pyuria, thick yellow fluid in their catheter bag. You're not going to miss that. But again, when you get a temperature, after discussion with the physician, they're going to order usually blood cultures, a chest X-ray, and a urine analysis, and try to look for any of the obvious sources of infection. So best practices, do recommend against indwelling catheters. So the use of an indwelling catheter should be used cautiously due to the risk of urinary tract infection. That's level evidence A. If used, they should be assessed daily and removed ASAP. Excellent pericare and infection prevention strategies should be implemented to minimize risk of infections. And this is a really turning point and a big point for discussion if you want afterwards, is there's this always balance. Well, Mr. Smith can't get out of bed. He has an NH score of 20. He's bedridden, but is he going to poop and pee all over himself and then cause ulcers and sores? So we should put a catheter in him. But then what happens invariably is the catheter gets forgotten and it's in there for a week or two, and then they develop a UTI. So this is actually a very big problem as well with older male patients who have big prostates and end up with retention. So they do mention that the use of a portable ultrasound machine is the recommended and preferred non-invasive painless method for assessing post-void residuals. So if you think your patient's not peeing or retaining, you can get a bladder scanner. We have those readily available on the floor. Or if the physicians are getting more comfortable with their POCUS and ultrasound, you can just put an ultrasound and see and measure the volume in the bladder. And we actually have a policy now, and we've done one of our family medicine colleagues wrote a nice paper on losing the tube, and that's our nursing sort of keywords to say, should we lose the tube today? So maybe in your rounds with the docs and the team, you could say the catheter has been in for 3 days. Can we perhaps take it out because Mr. Smith is starting to recover and starting to get a bit more mobile? I think we could transfer him to the commode. So always don't leave the catheter in. Don't put it in if you don't have to, and make assessments on the catheter every single day. Other common sources for infection are actually dental as well. I work in Merge. I'm seeing horrible dental care. But again, you can screen for dental disease, appliances, dentures. Often they're quite hemiplegic, so they can't brush their own teeth. And it's like on the 27th list of things to do for this patient. Oh yeah, you got to do some mouth care, and I should brush his one tooth. You know, this is things that I think are still important. Give a sense of comfort, whether you get family to help you brush the teeth. But if you can't find a source of infection, you have to look elsewhere, and often look in their mouth and also their skin. So if they've been hemiplegic, bedbound for a long period of time, everyone's aware that there are going to be common areas to develop pressure sores. It's either going to be in the head, shoulders, elbows, buttocks, heels, toes, whatever point of friction. And this is why it's very important to have a good routine with either your physio, occupational therapy, your nursing team to rotate these patients. Make sure that if they're sitting in a chair, they're not sitting always on one side, or always leaning on their arm and their elbow on the wheelchair. This is a very, I think, preventable part of our jobs as docs and nurses to sort of say, hey, we can prevent this. Of course, if they're diabetic, their skin, they're old, they're thin skin, this is going to be a big problem, and it takes forever to heal them once they start. So I think good foam or these intermittent pneumatic air mattresses are the way to go. If you see a mild stroke, you know, and they're starting to get mobile within 2-3 days, I don't think it's a big issue, but it's more the medium to dense strokes that are going to be around your either hospital system or rehab center for long periods of time that you know you can prevent these by getting proper good mattresses. And of course, nutrition. So nutrition is important for recognizing that patients who can't feed themselves will just get into a protein losing state, a stress state with lots of cortisol, and be immune suppressed, more prone to infections. So we have to make decisions. Can this patient swallow? So can they feed themselves or can they be fed? And this is where we talked about this initial screening tool. And we use the TORBEST one to see if they can actually eat. If they fail the TORBEST, then you, in consultation with specialists, either the doctor, a speech pathologist, a dietitian, can make decisions on what we should do to feed this patient. The other challenge is if they can't swallow, they can't take their pills. They can't take their cholesterol pills. They can't take their antihypertensives. They can't take their antiplatelets or their Plavix. So you have to make a decision. Will this person or patient be able to eat within a day or two? And usually I try to make that decision actually very quickly. They say recommend 3 days to make it NG, but you can kind of tell from the initial NIH and if they respond to the TPA or EBT quickly, whether or not we have to put an NG tube down. I think consultation with speech pathology is always an excellent idea. They have a very good schedule though, Monday to Friday. So if you're trying to get this on a Saturday, Sunday, you have to realize 2 out of 7 of your days, we have no speech and no dietary and no dietitian. So unless your hospital runs differently, but you can sort of make decisions on your own. If you see they're choking, if they fail the screening tools are very important and can be taught to anyone. In fact, a large percentage of our nurses do all the initial swallowing assessments. And they always have a list of who knows how to do the TORBEST. And if they can't do it, if they're too busy and emerge, I've done the TORBEST myself. So as long as you get the training, it's an important factor, because if they fail and you see that they're going to end up with aspiration pneumonia, I think there is a better way. And you put the NG tube in, you get them your pills, and then you can always reassess in 2 days, 3 days. If they're improving, you pull the tube and see if they can start swallowing when your speech pathologist is back. And then I think also consulting with the dietitian is important, especially if they're diabetic. So if they can't eat, you have to watch continuing all their diabetic medications. If they're on insulin, you might adjust their insulin if they're not eating. So I think it's important you decide feed or not feed, and then adjust their insulin and medication. Sometimes you hold them at metformin if they're not eating, especially in diabetics. And you can get a lot of help, a lot of suggestions with the dietitian. Do you have thickened fluids, thickened foods, sit them up at 90 degrees, make their head tilting? And this is all usually written on the whiteboard in front of the patient. And it's a very important part of preventing problems with inpatient stroke patients. So just to review, when do I call the MD stat? Because this is a tough decision for you guys. We come in there, guns blaring, we give the TPA, they're not an EBD candidate, we admit them to the ICU, and then we leave. But what happens 4 hours later? So I would call the MD, and we're the MRPs, and you should call them if you see a big change in the Glasgow Coma Scale or the NIH. If you're thinking hemorrhagic conversion, you see that bradycardia at 40, you see chain stoking, you see weird breathing, say, sorry, Dr. Kvas, I think you need to come in and reassess the patient. I'm worried this person is having a bleed, or I think a stroke is worsening. Like, that requires me to get in my car and come and see the patient. I might tell you on the phone, stop the TPA, stop the infusion. Often I'm still in emerge, or I'm still there. If this happens, I do often see this within the first hour of giving TPA. So it's not a great thing to happen, and the families have to realize that. But it is an inherent risk with giving this therapy. So I would call. Fever is always a tough one. So they develop a fever 4 hours after you give TPA, and they haven't had real time to develop a UTI. Maybe they aspirated, you don't know. I would call the doctor if there's any other signs of sepsis. So if they're tachycardic, heart rates of 120, they're hypotensive, they're looking warm extremities, maybe they came in with illness, maybe they had a pneumonia, maybe there was some underlying infection that precipitated the stroke. Is there something else? Maybe it was a stroke mimic. Maybe this is encephalitis, meningitis. These are things, I think, depending on the temperature, you can call the doctor and start the orders, draw some blood cultures, maybe gives a Tylenol suppository if they can't swallow. And but if you think they need antibiotics, they need assessment, get your doctor in there. When not to call, because I don't necessarily like coming in at 2 a.m. either, but I think these are on the to-do list, notify the AM. Most of the care paths will have these auto-generated check marks, but sometimes, like, and we're all human, they forget to check, or they say, I don't think he needs DVT prophylaxis. These are things you can bring up at the team meetings, or say, you know what, Mr. Smith hasn't really fed in 3 days. I think he needs some type of nutrition. I recommend an NG tube and a nutrition consult. And on that might trigger, oh yeah, I don't know why I didn't order that right away. And it may help the MRP physician to start thinking of these important factors. Skin breakdown, I think as nurses, you guys are the biggest advocate for their ulcer prevention. So say, I want to order a foam mattress. Well, we're out of foam mattress. Okay, what about an intermittent air mattress? So, you know, oh, well, we only have one, you know, okay, maybe that other patient is recovering 2 weeks from a stroke, is starting to get mobile. We can move his mattress or her mattress over. So there's a lot of juggling that you can do to try to prevent skin breakdown. And I'll tell you, as a caregiver, I think there is way more work to pack a wound, a sacral ulcer. This is work prevention. Once you have a big skin ulcer, is so much work to take care of in months, not weeks, months to heal them. So I think prevention is the key for that. And then DVT prophylaxis. I think, okay, no one ordered low molecular heparin. He's been 2 weeks. He hasn't moved. That would trigger a lot of questions and say, hey, we should have been championing the care path a little bit more. And unless there's a contraindication, unless he has a GI bleed, he has an intracranial bleed, there might be reasons, renal failure. They might have some weird platelet problem on heparin that you weren't aware of, but I think you can very much ask the questions and sort of see what they need. So I'd like to conclude here with some questions. And when you had too much fun charting, patient believes she is dead. Vital signs suggest otherwise. You guys are doing a fantastic job, and nurses holding it together during this COVID time. Everyone's overworked, no one's traveling. It's very important that you do take time away from your day to take care of yourself as well, and spend time with your family. So on that note, I'd like to thank Sue Verrilli again for inviting me. And if you have any questions, let me know.
Great. Thanks so much, Dr. Kvas. That's a great talk. I really loved the video at the beginning. Quite funny. A good way to start us off this morning. We're now going to take a few minutes for some questions. So please type your questions into the Ask a Question box, and I'll read them out for Dr. Kvas. Also want to remind you to click on the evaluation survey for this session. It can be found on the right side of your screen. Just take a few minutes to fill that in for us. So I'll start off with the first question for Dr. Kvas. As nurses, what would we be looking for to determine if they are having a second stroke?
So again, as stated in the previous speakers, I think you really want to look at the patient and see if their neurological condition is worsening. And that's why we do the standardized NIH-SS. And let's say they were moving their right arm, they could hold it above the bed for like 3 to 5 seconds, but now it's drooping. Their leg was moving or twitching a little bit, now it's not moving. So those are two things you have to worry about. Is the stroke worsening, or is there a hemorrhagic conversion going on or transformation? So these are the things I would worry about. And even that NIH score of 4 or more, if there's a change in their Glasgow Coma Scale, their level of consciousness, I think that requires reevaluation. Take the vitals, take a sugar, and make sure you call the doc and get them involved. And then they may order some repeat imaging to see if there is bleeding.
Right, great, thank you. When are you concerned about a temperature on a patient?
So this is a good controversial, different people have different limits for temperature. 37.5 was in Dr. Singh's note, and I was just texting him and questioning him about that, but he treats 37.5. As an emerge dog, I don't get too worried about that. The Americans sort of say sometimes 38.5, but if you see a temperature that's 38.5 or higher 2 or 3 days post-stroke, there's some infection brewing, and it's usually aspiration or UTI. Those are my 2 common ones that I see. So I think you have to let them know. You could treat it with Tylenol, but you have to always ask the whys. Be the Sherlock Holmes and say, well, where's this coming from? And then if you don't find anything obvious, roll the patient, take a look for skin ulcers. You have to take a whole look at the patient and see where's this temperature coming from. And then again, in our current environment, think COVID, right? So you probably will re-swab them, knowing that there's outbreaks in every ward and every floor. But yeah, 37.5, again, they're NPO usually right away. So if they do have a temperature initially, maybe give them a Tylenol suppository. But would I start culturing them? We tend to culture at 38.5. But we just know that people with higher temperatures don't do as well and have more risk for hemorrhagic conversion. And so you want to control the temperature very well.
Mm-hmm. Right, very good. Okay, I think that's all the questions coming in. Is there anything else you wanted to say before we move on for our next speaker?
No, I just think I have to tip my hat to Sudbury, that you guys have an excellent resource with yourself and Dr. Singh, and we're really enjoying working with you guys. And I'm so happy EVT is now in the north. And just let's hope for good weather so we can get our transport times good. And that's what my plug. And my plug is thanking the nurses for all their day in care that they do for the patients.
Yeah, agreed. Thanks so much, Dr. Kvas. We appreciate your time today, and please take care, especially when you're up working in the hospital in Timmins.
Take care. Thanks again for inviting me.
Yeah, thank you.